introduction of the company, I will introduce you to the audience and I will run the slides myself. Then I will ask you panel questions. Is that okay?
Yes, sir.
Okay, no?
Ashan, you can go live now.
Okay, thank you. Hello, doctors. Good evening and welcome to this experience sharing program on managing PPH. Case studies. Hello, doctors. Good evening and welcome to this program on experience sharing program on managing PPH. Case studies from labor room. Today we have got honorable speaker Dr. Sushma Kural with us. Welcome, madam.
Thank you, sir.
This program is brought to you by Heathrow Healthcare. Heathrow Healthcare is an innovative pharmaceutical company with 30 plus years of presence. We have got 25 years of excellence and 36 state-of-art manufacturing facilities with 300 plus products in our portfolio and presence in 126 plus countries. Heathrow Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Heathrow Healthcare is among the largest manufacturers of ARV, APIs, and FDFs in the world and is Asia's largest manufacturing facility at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is a 360 degrees solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Heathrow Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. During COVID-19 pandemic era, Heathrow Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patients, because of which, in August 2020, Heathrow Healthcare received an award of Pharma Excellence for COVID drugs. Today's program, experience sharing program on managing PPH. As I said, we have got honorable speaker Dr. Sushma Kural with us. Madam, Dr. Sushma Kural is an obstetrician, gynecologist, laparoscopic, and an infertility specialist. Madam has done her MBBS MS on obstetric gynecology from Manipal University, fellowship in minimum invasive gynecology from Bengaluru, fellowship in cosmetic gynecology, fellowship in fertility. Welcome, madam, and over to you.
Yeah, thank you, sir. Should we start?
Yes, madam.
Yeah. Good evening, one and all. It's a great privilege to be a
Voice
part
is
of.
little low, madam.
Should be okay, sir, now?
Oh, now it's okay.
Yeah. I take this privilege, and it is a great privilege to be a part of this academic event where we are talking. I'm going to talk about the most commonest or the most dreaded one of the nightmares which all the gynecologists, obstetricians across they are concerned and worried because PPH is one of the leading cause of maternal mortality, and unfortunately, it cannot be always predictable, though there are risk factors. Meanwhile, another thing is when timely intervened, we can prevent major mishaps. So, what is PPH? As we are all aware, it is basically blood loss following either vaginal delivery, which is more than 500 ml, or following cesarean section, which is around more than 1 liter of blood. And as we all know, it is a leading cause of maternal mortality, more so in the low socioeconomic status, and contributing for almost one fourth of the maternal deaths globally. So, PPH in the global front, if we see around the incidence is around 2 to 4% following vaginal deliveries and around 6% following cesarean sections. And 38% of, see, it's a big number, 38% of maternal deaths are due to PPH. And India, if we take in the global statistics, India accounts for about two-thirds of the maternal deaths due to PPH in the global statistics, which is very high, around 540 maternal deaths per 1 lakh live births, compared to 240 deaths per 1 lakh live births in developed countries. So it's a great difference that we can see here, and it is the leading cause for maternal mortality, around 35% of the maternal deaths. So, etiology, as we are all aware, the standard reading or the teaching goes the T's, which following delivery, we first rule out if the uterus is in good tone, that is the atonicity, the leading cause of PPH, which is attributed to atonic PPH, and uh, any tissue damage or the trauma to the tissues following vaginal birth or even cesarean, if there is any extensions, uterines have been given way during the extraction of the baby, or episiotomy extensions, cervical tears, trauma has to be ruled out. Coagulopathies, yes, of course, if the patient is booked, since all the antenatal care is done under a gynecologist, usually coagulopathies are not a surprise. They are picked up in the initial trimesters only. And lastly, the tissue part, that is any retention in cases of retained placentas or abnormal lobes, succensurate placentas, where there is retention and which is contributing to PPH. So, when a PPH happens, that clinically, when the obstetrician is alarmed, how what are the signs we look for following the birth? That is, we usually quantify the blood loss. Initially, the shock moves from compensated to uncompensatory. That is, if we quantify the blood loss, if it is within 500 to 1 liter, it is usually compensated blood loss. That is the degree of shock following uh, the delivery. And usually the blood pressures are maintained here, but patient has certain symptoms like lightheadedness, palpitations, and we on monitoring we tend to see usually there is tachycardia sets in. So moving on to uncompensated shock, compensated shock should alarm us. Timely interventions have to be started in immediately. We should look for any tissue damage, any injuries to birth canal or any extensions, retained placentas, check for the tone, and anyways coagulopathies would have been ruled out. So if the patient has already entered into shock, which can be quantified based on the signs and symptoms into mild, moderate, and severe, and also on the blood loss, less than 1500 ml but above 1 liter is mild, and 1500 to 2 liters, 1500 ml to 2 liters is moderate, and more than 2 liters should be severe shock, wherein patient usually the BP, the blood pressures are very low, patient is in hypotension, and there is multi-organ dysfunction. While mild, in mild cases, usually we see tachycardia, slight fall in the blood pressure by around 10 to 15 millimeters, both in systolic and diastolic. Anywhere in between mild and severe is a moderate degree of shock. The important golden hour, what we say in PPH, is to act immediately, to recognize even before patient slips into shock. That is, when the patient is still in compensatory shock or still in the initial part of it, and with nowadays with the active management of third stage of labor, the definitely the incidence of PPH is reducing, but still it is on the higher side. So, as already discussed, tone has to be checked initially, which is the commonest atonicity, wherein we check it by abdominal palpation with bimanual examination. If it is hard, stony hard, or are there any relaxations in between, uterus is not contracting well, and we also meanwhile secure wide bore cannula if the patient is having ongoing blood loss, check for any tears, trauma during vaginal birth, meanwhile secure a order for keep the blood and blood products ready, and as already discussed, if there is atonicity, we have to start with active management, which are already doing prophylactically with all the uterotonic agents available with us. We can choose wisely and accordingly manage. If there is any tear or trauma, that has to be addressed immediately, and any bleeders have to be checked. Sutures, stay sutures, hemostatic sutures have to be taken, and repair has to be done of the identified site. While if any retained tissue is known now, we also have ultrasound on as a good handy armamentarium. If following birth, if any retention, following vaginal birth, any retained bits can be immediately, we can do a check scan and then just we can plan for manual removal either under anesthesia or if the patient is cooperative in the labor room. Coagulopathies, yes, of course, if they have been identified, respective blood factors should be taken care. Multidisciplinary approach, physician, hematologist should also be on the board. Yes. So, what is the rationale and what is the rationale in using the uterotonic carbetocin? Carbetocin, it is a oxytocin, synthetic oxytocin analog. It is nothing but an oxytocin analog, which is a stable form, that is temperature stable formulation, analog of oxytocin itself. How does it differ from oxytocin is it is stable at room temperature, does not require refrigeration, and the shelf life is also longer, approximately 20 to 24 months, and even can be stored up to temperatures of 30 degrees, does not require any cold chain storage, unlike oxytocin, and usually comes in a vial form. So, what are the uterotonic agents available with us? That is, we are all aware of oxytocin. Carbetocin is the newer molecule, which all of us have been using since long. Methergin, that is ergometric. Symptometrin, which is combination of both, and tablets misoprostol. So, what is active management of labor is administration, timely administration following the delivery of the baby. As the baby, as even as the baby is being delivered, the active management has been done, and by after the placenta is also delivered, we administer uterotonic agents, not waiting for the PPH to happen. This is the prophylactic use to prevent PPH. This is active management of third stage of labor. So, as already told, carbetocin is nothing but it is a synthetic analog of oxytocin and it is long acting when compared to oxytocin. Oxytocin has just action for about 3 to 5 minutes, whereas carbetocin is long acting. And the indication is prevention of PPH due to atonicity. Prevention of PPH due to atonicity. And carbetocin was created. That's what, since it's an analog, it is being created by making multiple modifications in the basic oxytocin structure. So one vial, whatever is available, it contains that is 1 ml of 100 microgram, 100 mcg of carbetocin. So what the evidence has to say, why have we to choose oxytocin? Why have we to choose carbetocin over oxytocin? So it is a long-acting synthetic analog of oxytocin only, which means it goes and binds to the oxytocin receptors present in the uterine muscles, resulting in contractions, rhythmic contractions, preventing atonicity. And the contractions frequency are increased. That is, the uterus stays contracted for longer time, and relaxation is reduced, thereby improving the uterine tone. How different it is in pharmacokinetics from oxytocin is the onset of action is early. We can administer in two routes, IV and IM. In IV, the contractions are sustained for about start within 2 minutes and sustain for about 5 to 10 minutes and followed by continued action for nearly an hour with carbetocin being administered IV. But when we are giving IM, the contractions last even more longer, more than 10 minutes, and the sustained effect is obtained for around 2 hours. And the How is it different from oxytocin? Carbetocin has a longer half life, that is approximately around 45 minutes compared to the 3 to 5 minutes half life of oxytocin. And storage, as already discussed, it is temperature stable, heat stable, so it can be stored even without refrigeration up to 30 degrees Celsius, being heat stable, but it is used only as a uterotonic, cannot be used, unlike oxytocin, in induction of labor or augmentation of labor. So the only indication goes prevention and treatment of, sorry, prevention of PPH, not the treatment. So there were trials which was conducted in two phases, that is WHO champion trial, that goes Carbetocin hemorrhage prevention. Carbetocin hemorrhage prevention trial, and it is one of the largest trial. And the phase one publication, that study of the phase one, the primary outcomes were the proportion of women with blood loss of at least 500 ml was the primary outcome which was studied, or the use of uterotonic agents, and the proportion of blood loss lost of at least 1 liters. And it was, the objective was to compare the effectiveness and also the safety profile of carbetocin to oxytocin. It was done in women only following vaginal births. So we, as we see the trial, and we can see what was the result, and we get to see almost the blood loss, the efficacy, both oxytocin and carbetocin, it was comparable, that is around 14.5%. Blood loss with respect to more than 1 liter was also comparable. Safety issues also, safety efficacy also, carbetocin showed a good safety profile. And the frequency of blood loss, at least 500 ml, or the use of additional uterotonics was not proven to be any inferior than oxytocin. Means both were comparable in their uses. And the use of additional uterotonics to stop bleeding and the adverse effects did not differ either in the oxytocin group or the carbetocin groups significantly. So this is a Cochrane review, and let us see what the Cochrane has to tell us. It showed data of around 11 studies, and it involved a big number of women, that is around 2,600 women were included. For women who undergo caesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. So they found that who underwent cesarean section, in the champion trial it was vaginal birth, and now Cochrane is giving the review regarding the 11 studies which showed that additional use of uterotonics was significantly reduced when carbetocin was used for prevention, and carbetocin was also associated with a lesser amount of blood loss when compared to symptometrin in prevention of PPH for women who had vaginal birth, and showed a safety profile, did not show any additional side effects. So, what are the guidelines and recommendations? We have various recommendations. As we can see, the FIGO recommendation says that carbetocin is one of the recommendations for PPH management, and this is for PPH management. And WHO, by going by the 2018 WHO recommendations, carbetocin is also included in the list of management of PPH prophylaxis. Others being New Zealand, Canada, Germany, all these also showed safety profile and supported the use of carbetocin for PPH management. So this is a question, that is what has been my experience with use of
Yes, madam. Since
carbetocin.
how long you have been using
Yes,
carbetocin?
sir. Sir, I do a lot of laparoscopy work.
Okay.
And my obstetric load has been not that, means I
Understood.
don't cross around 20 cases per month, but that is also a good
Fair
number.
enough. Yeah.
Yeah, the thing is that number is also, they come with a little high risk, having conceived following a fertility
Yeah.
treatment. Or so I have been using almost for 3 to 4 years carbetocin now.
In every patient.
Yeah, in every patient from last 2 years, and priorly, yes,
Yeah, yeah, off and on.
oxytocin, methergin, and also from every patient from last 2 years. Yes, sir.
That's lovely. It's quite big, about 20 patients a month, and for the last 2 years is a big experience. And madam,
Yes.
generally, which route you prefer, IV or IM?
Sir, if we are in the OT, anesthetist will be holding the
Yeah,
carbetocin
yeah,
and
that
they are
is
going
correct.
to give it
That
IM
is
only.
correct.
They're giving it IM. Honestly, they're giving it IM.
That is correct. And IM route is
And
a great advantage even in the interiors, where we may
yes, it
not
is
have a
a
lot of
great
facilities.
advantage in the interiors. And when we especially have in the labor room, sometimes our trained staff are absent, patient is in
Yeah, yeah,
labor.
it always happens. No?
Yes.
And suddenly, sometimes there are 4, 5 deliveries. I mean, everyone is put at stress. I mean, these are all unexpected
Yes, yes.
situations.
That situation has not arisen with me. I'm into a private practice and we have
Okay,
another doctor also.
that's good.
Two
That's good.
obstetricians we are.
In our,
So on an
yeah,
average 10 to 12 deliveries each obstetrician is doing. But
that is good.
I think, sir, over the period, what first thing, because antenatal cases are getting booked and most of our patients have been following up with us. We have ruled out PIH has been controlled,
Yes,
anemia
yes,
has been on a proper, we are taken care. All these, as we are reducing the risk factors,
yes, yes.
the
And
PPH
you
is
mentioned
getting,
even coagulopathies are diagnosed
yes,
early. Yeah.
yes, we would have screened for them.
And with this screening, even the major risk factor anemia is also handled.
Yes, sir, anemia is
Yes.
also handled. In
Yeah.
fact, because of the acceptance and regular ANC's, use of parenteral iron has also reduced a lot over a
Absolutely,
decade.
absolutely. That's
Yes,
wonderful to hear. Huh? That's very great. I mean, it's because I have seen hemoglobin up to 4 or 5, and so at
yes,
that
sir.
point of time, it was the best in the
Yes,
interiors of
yes, yes,
Maharashtra. Yeah,
yes, yes,
and
yes,
we
yes.
know with iron, low iron, it's a big risk
Yes,
in our
yes,
country.
yes,
That's a major
PPH,
risk.
yes. It is a nightmare. It's a double trouble. Anemia and PPH.
And I'll tell you, this is one topic which is excellent to discuss, but one
Yes,
should
yes.
never get a patient of PPH.
Never get a patient, sir. Never, never, never.
And as you rightly said, it's expected unexpected. You never know which patient will land.
Yes, yes.
Yes, in my experience, I've seen a patient
So
normally
last week only, third gravida delivered with me,
okay,
4.2 kg baby, because her
okay,
two deliveries were normal. They were not with me. They were at her mother's place. And
okay.
now, since it was third, I delivered 4.2. As expected, I was expecting she was multipara. I was
Yeah,
expecting
correct.
and big baby,
Oh,
but she was not in prolonged labor. She came in labor within 2.5 hours. She delivered. She progressed well. But with carbetocin, I didn't have PPH at all up
lovely.
to
That's very
7.
great to hear.
Yes,
And
yes.
any major side effects you have seen with the drug?
Sir, with carbetocin, honestly, no, sir.
Very
No,
good.
no, no,
Very.
no. Actually, oxytocin, if the infusion goes faster, we see little bit of
Yes,
hypotension, patient
yes,
complaints of
yes.
headache.
And rarely ADH related side effects also if it's a prolonged
Yes, yes,
duration. Yes.
yes,
In
yes.
fact, my daughter-in-law had twins, and the only thing I was worried is PPH,
Yes,
because
sir. Yes, yes,
yes.
definitely. Yes, sir. Yes,
Now coming to some of these panel questions,
yes.
why is the incidence of PPH more in India?
Yeah, again, because India is mainly a rural dominated
Yes, yes,
country, and because of the low socioeconomic status,
correct.
anemia, prevalence of anemia,
Yes, correct, correct.
ignorance, poor nutrition,
That's correct.
and even with rising, if they are unbooked, we see PIH also causing PPH
You're
actually.
correct, 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 correct.
Yeah, so
That's a risk
this is,
factor finally. And
yes.
many of the patient must be coming in the 8th month, or I mean, even the
So
doctor
that
can
is
do very
reduced,
little.
sir,
Yes,
actually.
that is reduced.
Reduced,
That's a
actually.
great thing. Yeah.
Reduced, reduced, reduced.
And although we can get PPH in any patient, what are the general patient profiles where a doctor can anticipate a PPH?
Yeah, PPH again, sir, as we said,
Every patient. Yeah, I should
every
not ask
other
this
patient,
question. We
be
know.
it a low risk,
Yeah,
be it a high risk, we have to be on our toes.
absolutely.
Nobody can escape this. So,
And a normal patient going into normal delivery suddenly ends into PPH for unknown reasons, and then we are all at
yes,
mess. Yes.
yes, sir, yes, yes,
Yes, you already answered this. I don't want to
yes,
take your time.
definitely anemia is
Besides carbetocin, and prior to carbetocin, which other drugs you have used for prophylaxis of PPH prior to
yeah,
carbetocin?
yes, like we are using oxytocin in
Yes.
the since with the carbetocin in OT, what is happening is, because we are trained with tuned with our anesthetist, they put in the RL, they put 10 units of oxytocin, and IM 100
Correct.
mcg of carbetocin is given.
Oh,
And
simultaneously they give. Huh.
yeah,
Huh.
this carbetocin is given of IM, and
Huh.
nowadays methergine also we are not giving if there is a cesarean. But
Correct.
in the once the normal delivery happens and anterior shoulder as the baby delivers,
Yes.
our sisters are trained to give methergine. They give off
That
methergine
was our
unless the
protocol some
patient.
time back. Yeah, that was our
Yes, yes,
protocol. Yeah, that was a
yes,
protocol.
and unless there is PIH, methergine with oxytocin.
Correct, correct, correct.
Otherwise, since we've added on carbetocin, we just tell no, sister, give carbetocin
Only
also. And
carbetocin.
misoprostol, yes, after delivery, everything episiotomy sutured, we are keeping my unit protocol 4 tablets of misoprostol per rectally. We are keeping
Okay. With every
800.
episiotomy case.
Yes, yes.
I mean, you have already answered this. In which cases, you know, now you said that you have got anesthetics you will use for IV, but generally you would prefer IV route in any specific type of risk factors, or generally depending on anesthetics availability.
Sir, it is, see, because carbetocin is safe, lesser cardiovascular side effects also. It
Correct,
does not cause
correct,
vasoconstriction.
correct,
It can be used in high blood pressures also.
correct.
But discussed with anesthetists, they say that we will give it IM only, because with IM also in 10 minutes it will start the
Absolutely.
action.
And many of the time the duration of effect is also longer.
Yes.
And sometimes we get a PPH
Sustained
even after
effect.
1 hour or so. And I mean, the secondary
Yes.
patient, suddenly the patient
Yes.
happens. That's the time where it can protect better.
Till now, IV routes I have not given only actually.
Very good. No, no, if you're happy,
Mhm.
why should you do something different? No? How fast it acts in your experience? Although the data says whatever minutes.
Yeah. Maybe I think IV it should act immediately, because it is like a oxytocin analog
Absolutely,
only.
absolutely.
And
Straight away going
IM
on.
route, it should maybe it will take 4 or 5 minutes and it will act. So not much of a
I mean,
difference.
it will last for about an hour or two or
Yeah,
something like
the
that.
last for IM routes last for 2 hours,
2 hours.
more than an hour. IV routes also should last, sir, one to 2 hours.
Madam, you think that 2 hours lasting is little important, especially for the from secondary PPH point of view? Because many patients land up with, we have
Yes,
seen
yes,
for,
definitely,
yeah,
sir, definitely. That's why I think we should prefer IM route cycle.
I'm correct, correct. I completely agree with you. And in fact, international guidelines also recommend IM route for a vaginal delivery and IV, of course, for a cesareans. But otherwise,
Okay.
IM. Any experience of using carbetocin in RH negative mothers?
Sir, no contraindication. I
No
have been using
contraindication.
for all.
Yeah. No, this is interesting. I mean, you have not seen any PPH after the carbetocin, God bless. So this question I don't want to ask you also. It's more of a theoretical question.
Sir, actually, PPH only is reduced, sir, so
Yeah,
much
that's what
that
I said. I mean, you have been using and you have not got PPH, and I wish you don't never
touch
get
wood,
a
and I
PPH.
don't
Yeah,
intend,
yeah, yeah,
none
yeah.
of us,
Okay.
none of us, none of us, sir.
Correct, correct, correct.
Yes.
And then do all patients with uterine atony, we know atony can be because of several reasons. Do all patients with uterine atony can get benefit with uterotonics, including carbetocin?
Yes, definitely, because the cause is only smooth muscle
Smooth muscle
relaxation, and these are
relaxation.
going to act on the muscles
Correct,
receptors, and
correct.
they will, unless there is any additional any return
Okay. Yeah, yeah, yeah.
which we have missed. Otherwise, it should benefit.
And with patients with those fibroids, does it act well?
So fibroids intrinsically also will hamper the
Hamper,
contraction.
yeah, contraction.
Huh. If there is any structural defect,
Correct.
largely
I mean,
fibroids
you're
and
well
all
said.
should,
Structural, yes, yes,
yes,
yes.
yes. But I had a patient with multiple small fibroids who had conceived
Okay.
spontaneously. I think she was around 30 years,
Ah,
and multiple fibroids on and off during the pregnancy. Because of the degeneration, she had pain. We had to deliver her by 36 weeks because PIH.
yeah.
In her also, I used carbetocin. She did well.
That's very good. And as you said, if the patient's anemia status is corrected, the contraction also becomes more forceful. I mean, it also
Yes,
aids.
yes, yes, sir.
It's the overall factor, not only carbetocin, the overall
Yes,
care of
yes,
the
yes,
patient.
yes, sir.
Even if PPH occurs in spite of using carbetocin for prophylaxis, do you feel that there could be a reduction in PPH, a reduction in terms of blood loss?
Yes, because actively we have done the third stage
Yes,
management,
yes, yes, yes.
and there should be that PPH occurs in spite of that, means she's having a tendency. As we know,
Correct,
PPH cannot
correct.
be predicted in all.
Absolutely
This,
correct. Yes.
yes. So then we have to escalate our management
Correct.
and start with all the mechanical methods, buckery,
Yeah,
and
yeah,
other
yeah. Everything that's
devices.
possible. Yeah, yeah.
Yes, yes,
Correct.
yes.
I mean, this. You said it's well tolerated. Madam, I suppose the advantage of using carbetocin, to me, a single advantage is the storage condition. Huh?
Yes.
Because we know the
Ease
power
of
outage.
administration, storage,
Correct.
multiple, like oxytocin even needs a drip infusion.
Yes,
So
absolutely.
this is just, don't know
One,
anything, just give an IM.
I mean, just an idea. Does this pre-filled syringe of carbetocin, you think it would be a good idea? A pre-filled
In a
syringe?
syringe, like a vaccine, as it is
Yeah, yeah,
pre-filled
straight away. Now you
syringe.
get pre-filled syringe straight away. I mean, put it in the theater straight away,
Should
remove
be,
the
sir,
cap, and
should be.
I
That
mean,
should be
every
great.
second saved is great here.
Yes, yes. The golden hour. Yes, bro.
Yeah, correct,
Yes.
correct.
Yes, yes.
And do you have you? I mean, do you use tranexamic acid prophylactically or only if there is a bleeding?
Prophylactically, I am not using. Some my seniors and colleagues, they
Yeah,
have
some
been
people
giving just at
use.
the
Yeah,
start. As we take the incision for C-section, they give one
they give
gram
tranexamic acid.
tranexam. I'm not using, sir.
I mean, each one has its own. What is the benefit of using carbetocin as a first line in every patient for every delivery? Now you have been using. Obviously, there is no incidence of PPH, which itself is a great benefit.
Yeah, it is a great benefit, and as you say, as we said, we the storage part, heat stable part,
Correct.
and lesser cardiovascular. We don't have to put in our head, no, this is a PIH patient. Don't give
Yeah, yeah, yeah,
mentorship.
yeah, yeah, yeah.
Patient is having nausea, vomiting, full stomach, emergency cesarean, because less of nausea and
Correct,
vomiting.
correct. And that
And even, yes,
yes,
post-op, yes, as you said, sir, 2 hours is an important
correct,
period.
correct, correct, correct.
Yes.
And madam, that prostaglandin related side effect, asthmatic and this, many patients do
Yes,
not give us
exactly.
history of
Sorry,
this
sir. I
being
missed him.
asthmatic.
What? Yes,
Yes,
yes. That side effects, and even with misoprostol, so many times we see chills and
absolutely.
shivering.
And in
That
the
also is
golden
not.
hour getting chills and I mean, it's little
Yes, yes, yes. And very importantly, carboprost, otherwise contraindicated in asthmatic. So there
Absolutely,
is no
and
such.
our patients don't give that history, past history. For
Yes, don't give.
them,
Yes,
if they don't get an attack for a year, it's gone.
yes, sir. Yes.
Yes. To conclude, madam, it is a lovely webinar. To conclude your overall experience of using, take home message for the audience.
The take home message should be that be on your toes, irrespective of the uterotonics you have. And if we have not been started using carbetocin, one of the wonderful drug, should try. No offense to oxytocin, methergin,
No,
or
no, 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 no.
misoprostol, which
They
have
are
been
all
with
textbook
us
brands.
from decades together.
Yeah.
But yes, this molecule should be tried, and happy practice and safe practice.
Madam, thank you so much. It was a lovely webinar. I mean, your experience is amazing, madam. I myself got a few points in it. Thank you. In fact, that is exactly what our doctors want, rather than reading the literature, which is one part of
Yes,
it. Our own
yes,
doctors using is lovely.
yes, yes.
Thanks so much, and thanks all the
Thank you for
doctors.
your time, sir. Thank you for your
Madam, our pleasure,
valuable
madam.
time.
Thank you. And thanks
Thank you.
all the doctors who took time and attended this webinar. Thank you, marketing sales team of Hitro for coordinating. Thanks, IT team for your coordination. Once again, thanks, madam. Wish you a very pleasant
Thank you, sir.
evening.
Thank you.
We can log
Thank you,
off,
the
madam.
entire
Thank
team.
you.
Thank you. Thank you.
Thanks, Anjana. Thank you.
Thank you.
Okay. You can log off, madam.
Yeah. Okay, sir.